Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on managing ART with opportunistic infections, featuring Cristina Mussini, head of the Department of Infectious Diseases and Tropical Medicine and full professor of infectious diseases at infectious diseases clinics at University Hospital, University of Modena and Reggio Emilia in Reggio Emilia, Italy, and William Short, Associate Professor of Medicine in the Division of Infectious Diseases, Department of Medicine at the Perelman School of Medicine at the University of Pennsylvania in Philadelphia, Pennsylvania. They'll discuss key considerations for the use of ART in the setting of opportunistic infections, and following their dialogue, they'll field questions from healthcare professionals. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Drs. Mussini and Short.
Great, thank you so much. So thank you everyone for taking time out of your day to join us. I know people are joining us from across the globe, so good morning, good afternoon, good evening, whatever it is where you're at. Again, thank you for allowing us to present this really important data and information. And so I just want to start before I delve into the slides. Many of you are not used to seeing webinars on ART and opportunistic infections. And the question is, why is this even an important topic? It's 2022, you're talking about 40 years after this virus was first introduced into the world. So why are we talking about that many, many years? I think it's important to remember for many individuals who have access to care, there really is a dramatic change that has been brought about through antiretrovirals and everything else that has come forward with testing and all the treatment advances. However, there's a subset of patients who still are unaware of their HIV status, or if they are aware, for many, many, many reasons, one of the largest being stigma, they have chosen not to come into care and are off ART and really are unable to reap the benefits that we see. And so we do have patients present with this. And I think it's important because these conversations come up, and as you see, as we both go through our presentations, that managing these cases are very complex and they require certain intricacies in terms of timing of ART, when you can and cannot use steroids. And really what you want to do is make sure you do no harm. And I have to say, before we even delve into this, if you're unsure, it's not a problem if you go back and look this up. I always do. Every time I have someone with an OI, I make sure I have the most up-to-date information because I want to make sure I do no harm, because data are still emerging. It's just that we lately have all been focused on management of ART without OI. So let's delve into our first case. So this is a 35-year-old female, presents with a 2 to 3 week gradual onset of shortness of breath associated with weight loss and dysphagia. Sounds very classic, right? Very classic for PCP. On exam, you notice this person is bitemporal wasting, person's febrile, tachypnic, and has oral candidiasis. So right off the bat, before you even see, this person's very sick. So this has been going on for a couple of weeks. They have a fever. They're starting out tachypnic. You haven't even started treatment. You do a chest x-ray, there's bilateral multifocal infiltrates. You do an HIV screen because this person's not been diagnosed and has actually never had an HIV screen. You get a reactive screen and you have a confirmation of an HIV-1 antibody afterwards. You send off labs, CD4 viral load genotype. I'm going to go through the labs in a second, but really all that has come back and your genotype is still pending. You start the patient on trimethoprim sulfa, 5 mg per kg IV Q8, because the patient has no history of documented allergy to either component. And because the patient is breathing very fast and has a low oxygen saturation, you again add steroids, which is really part of the standard protocol. Unlike what you would see here, you would think this would be a straightforward case. This person actually clinically deteriorates and gets intubated. And you do a confirmatory test to find out this person does have pneumocystis. Just some key highlights here. I'm not going to go through everything, but you see this person has a CD4 count of 20. So this is a nadir of CD4 of 20 and a virus load of 125,000, a low BMI, and then the GFR is greater than 60. And remember, that's important because you're using trimethoprim sulfa, which we know can cause problems with nephrotoxicity as well as hyperkalemia. So you want to make sure you're on top of that. So question comes up is, while you're managing the opportunistic infection, you're given the steroids, you're doing the ventilator management, you're managing everything there, and you have someone come and say to you, when would you start antiretrovirals in this patient? And for a long time when I trained, it was taboo to even consider starting antiretrovirals in this setting. You always waited till they came to the office. And then this landmark study came out. It was an ACTG study, 5164, led by Andy Zalopa, that really asked that question. Do you start ART immediately, or do you defer it in patients with active opportunistic infections? Before I even get into what happened, I think it's really important for you to put in your head, because when we go to Dr. Mussini's talk, she's going to really lay out some differences. So I don't want you to walk away thinking this answers every question. There really ought to be differences when you start talking about cryptococcal meningitis or tuberculosis. So in this trial, it was clear patients with TB were ineligible. So that was an exclusion criteria. So what were the most common OIs? The pneumocystis was the most seen in 63% of the cases, crypto in 12, and bacterial infections. I actually went back yesterday because a question came up. There was some toxo in there as well. So there were smaller percentages, but really it was largely on pneumocystis. And what happened is you saw that within 48 hours of randomization, the patients were to start ART within 14 days of an acute OI treatment. So that was the immediate arm versus waiting till you completed the OI treatment. And that was called the deferred arm. And that was somewhere between week 4 and week 32. And what you see clearly is that their rate of AIDS progression or death, which was their primary endpoint, was 14.2% in the immediate versus 24% in the deferred arm. And you can see that clearly here between the two curves. So in the dark blue was the immediate ART versus the deferred. Interesting enough, when we look, these patients had low CD4 counts to start. So your concern, theoretical concern at the time, was if I give someone antiretrovirals, one, you have a low CD4 count, maybe a high viral load, but you also have an active infection. Was that going to make the case for paradoxical immune reconstitution inflammatory syndrome? And what you saw from the study, which was key, is that there was no difference in iris between either arm. So 6 in the immediate and 9 in the deferred. So really, this is the standard when we talk about how to manage PCP. This is just going over when to start. And this is a really nice guideline from EACS, the DHHS, and the IAS-USA. And this is in general. And we really have in the field moved to starting antiretrovirals as soon as possible, largely for 2 reasons. One is for decreased transmission. We know that treating someone with HIV to lower the viral load really decreases the chance of transmission to the partner without HIV. But also the START trial showed that as a result of delaying, there was an increase in AIDS-defining and non-AIDS-defining illnesses. And really that set the stage for really a change globally for when we actually start antiretrovirals. It really is at diagnosis. We no longer have CD4 thresholds. However, when you look at patients with OIs, you can see straight down, most of them say within 2 weeks. And again, Dr. Mussini is going to cover, and I think it's important that we cover this, areas where it's a little different than within 2 weeks of starting your opportunistic infection. So what do you do, and what ART regimen? Say you do not think this person is going to be able to get extubated within that 2-week time frame. So what ART regimens do you consider for this patient with PCP who's intubated and unable to swallow? Here's some data, and I want to draw your attention to the bottom. Both have great resources. I use the one on the right, the PDF format, the most because I can print it out and it's updated every year. And it really goes through which tablets can be crushed, which tablets are there liquids available, and which tablets cannot be crushed. And I think this is important because things change so much. This table here is a condensation of all those guidelines. And I think if I was going to put this patient on a regimen, let's just say I would go with, what if they weren't intubated? I would either go with a single tablet with an integrase inhibitor and probably TAF, and if not, maybe 2 single drugs. So you go looking here to see what data do we have. And what you can see is when you go down tablets can be crushed, you go down to integrase, you can see dolutegravir can, raltegravir can. The one thing that's listed here as can be crushed, and I just will advise some caution, it says things with TAF. And if you look up here, TAF. And when you actually look through this document, per the package insert, TAF cannot be crushed, but there are case reports of people having crushed. So again, I leave you to draw your own conclusions. I tend not to do that. And then I wind up using a TDF-based regimen, which I can crush, and then later switch to TAF when they're extubated. For some people, you may say, well, this person's they're very sick. They're on high-dose trimethoprim sulfa, 15 to 20 mgs per kg, which is a lot. And then you have TDF, which may be nephrotoxic, so maybe I'll hold. So I think this does get complicated, but if you go down, something like dolutegravir is very easily crushable. All right, so let's switch gears now. We're going to talk about Kaposi sarcoma, something you don't hear about a lot in lectures, but I think it's worth bringing up. So here you have patient case 2, and you have a 28-year-old male diagnosed with HIV 2 years ago, but again, lost to care and now comes to reestablish. When you examine him, you see a couple things. He has a couple raised nodular purple lesions on his hard palate and 2 to 3 raised purple lesions on his chest. I stop here like I did yesterday, and I won't prolong it, but I just encourage you. I know you do it, but if you don't, please do it. Please examine inside someone's mouth. There really is a host of pathology that you can find. It's not just thrush. You can find oral lesions. You can find gingivitis. You can find decaying teeth. I mean, there's all leukoplakia. There's a lot of things you can really gauge from someone by looking in the mouth. I'm not a dentist, but I look at everyone's mouth, even if they're coming in for a short visit. So sometimes, and you'll see later that sometimes the oral may be the only place where you see these lesions. Patient was sent to dermatology for a biopsy, and what you see back on histology, it has things suggestive of Kaposi sarcoma, and then the HHV-8 is positive on molecular staining. You do evaluation, and there's no evidence of visceral Kaposi sarcoma. This person's numbers, the CD4 count's 100, the viral load's high. You can see all the rest of the parameters. So let's talk a little bit about KS. So this is human herpes virus 8, and that's associated with all types of Kaposi sarcoma. So remember, there's a couple different, there's the classic, there's endemic, HIV-related, and transplant-related. But if you look at all of them, HHV-8 has been associated with this, and that's really what you saw from your molecular results. Occurs most frequently among patients with HIV that have advanced immunosuppression with a CD4 less than 200. I will say, and someone brought it up yesterday, and I think it's important, that we have started to see cases in patients who are virally suppressed. So CD4 counts above 500, they're virally suppressed, and they actually have evidence of KS. That has occurred as well. Most patients present with hyperpigmented, non-tender macular or nodular skin lesions. 1/3 have oral lesions. And again, that really is important. And it tells you that you should really be looking inside someone's mouth. Patients can have visceral involvement that may be symptomatic there for the pulmonary, their GI tract. So when I see someone who I see a cutaneous lesion, I always get a chest x-ray. I look for pulmonary symptoms. I make sure there's no blood in their stool and make sure they have evaluation there. So it's really important to sort of rule that out. And again, I told you about diagnosis. Diagnosis really is cytology and immunologic cell markers. Histology as well, but not exam. So just looking at a lesion is not sufficient to say that's Kaposi sarcoma. You do need a biopsy. And one of the differentials that comes up is this bacillary angiomatosis. When you look at treatment, there's sort of a standard treatment, and that's usually for someone who has visceral involvement. So the standard of care if someone just has cutaneous is given ART and controlling their virus to the point of viral suppression. If they have visceral, you want to give ART, but usually that's combined with chemotherapy. And there's usually 2 forms of chemotherapy that are given. So it's liposomal doxorubicin and paclitaxel. Doxorubicin has less toxicity and preferred first-line treatment. So that's usually started with. And again, both show very similar responses. So it's just that if you have 2 drugs with 2 responses, which one do you go with? You go with the one that has less toxicity. How about ART regimens? So you have someone who has visceral KS and you want to then start them on ART treatment. Do you have any concerns? And the answer is potentially. So if you're going with doxorubicin, you can see down here in green, most regimens, and this is pretty up to date, so bictegravir, dolutegravir, raltegravir, which is really what a lot of the guidelines recommend, you have no interaction expected. When you get down into atazanavir, you definitely have some clinically significant interaction. You may want to avoid it. Same thing here with rilpivirine. Paclitaxel is a little different in that you do have some issues here, and largely due to cytochrome induction. So you have some cytochrome induction and basically can lead to lower levels of your HIV drug. So you want to be cautious there when you're starting. Going to finish up with some other special considerations. So in addition to looking at which drugs am I worried about, what are there going to be in drug-drug interactions, we know that we definitely, as part of your treatment plan for someone key at KS, you absolutely should be on ART. So avoiding those drug-drug interactions is key. Lack of evidence suggesting that one regimen's superior over another or better. In the old days, I think when I trained, that there was a theory that protease inhibitor-based regimens were better. And I don't think that is held out to. There's really not enough evidence to support that. It's just really controlling that virus. You always want to be concerned about IRIS when you start someone ART, and there's two types. So someone who has no known history of KS, you start them on ART, and then they get new lesions. We call that unmasking. Then the other one is paradoxical. You have someone who had KS. Obviously, I told you ART is part of the standard of care. You start them on ART, and all of a sudden, these things get worse. So how do you treat KS-IRIS? Well, at this point, you maybe need to consider systemic chemotherapy with supportive measures. And I'm going to draw your attention here because this is the one time you'll hear us talk back and forth about IRIS. So I just talked about PCP, standard of care as they go on steroids, more so part of the protocol with trimethoprim. But here, if you have someone with KS-IRIS, steroids are strongly discouraged because they've been associated with really aggravation of pre-existing KS. So you really want to avoid steroids in that condition. So with that, I'm going to turn to Dr. Mussini, who will take you through two other opportunistic infections, and I'll come back at the end with questions. Thanks.
Thank you very much, Bill. So our first case is a 52-year-old male admitted for shortness of breath. So you have already heard about a story like this. HIV testing was positive, and bronchoalveolar lavage fluid resulted in diagnosis of PCP. But as it happened very often, and we are seeing so many late presenters in this COVID era, patients present with more than one opportunistic infection at the same time. So while he was receiving treatment for PCP, he reported seeing black spots in the right eye. So he was seen by an ophthalmologist, and he was diagnosed with retinitis. I mean, fundoscopy is really part of the baseline evaluation of a late presenter patient, even if the patient is not complaining about any visual symptom, any visual alteration. So, but in this case, he was complaining, but even if it's not, you should ask for a fundoscopy. And as it happened for a localized CMV infection, CMV DNA in blood was negative. Is it not surprising that this patient had a very low CD4 count, because the two opportunistic infections that I will talk about are characteristic of the latest stage of HIV infection. And so his CD4 count was 20 cells, his viral load was above 150,000, and his BMI was 23. That was, a low BMI is characteristic of the wasting syndrome, so the latest stage of the disease, and as is the low cholesterol. These are two pictures of the retinitis, and we know that this is a retinitis that is peripheral, is not at the fovea, while here is an iris, is a paradoxical retinitis due to immune response. It is not the only way that iris is presented. At first, we have to see that iris is not predictable, but it's more frequent in those who started antiretroviral with a very low CD4 count. As you can see from this study that was published out of 13,000 cases of iris, 13,000 cases of late presenter, and the iris was developing almost 1,700 patients. And you see that with the decline of the CD4 count, there was an increase in iris. And this was typical of all opportunistic infection, not only of a specific opportunistic infection. So there are some special considerations that we have to take into account when we should start antiretroviral in patients with CMV, because we have to know that apart from iris as a paradoxical retinitis, we have also uveitis that is, again, very visual threatening for the patient. We know that the iris can occur not only in patients with an active retinitis, but also in patients who had recently a retinitis or even had a CMV retinitis. So it's something that we have to keep in mind, that when we have an immune reconstitution syndrome, we have to look at the eye, okay? So the likelihood of severity of immune reconstitution uveitis may be decreased by delaying art until retinitis is controlled. This is something that we have to keep in mind. Exactly as what Bill was saying, the graph of the study by Zolopa of the ACTG 5164, it really applies to most opportunistic infections, not to all of them. And CMV is one of the excluded one. If delaying art, consider possibly also the possibility that we put the patient at risk of developing other opportunistic infection. So it's always a decision that should balance the risk of new opportunistic infection and the risk of losing the eye. Because CMV replication typically declines within 1-2 weeks of anti-CMV therapy, most guidelines will suggest to start antiretroviral no later than 1-2 weeks after initiation of anti-CMV treatment. And this is true not only for retinitis, but also for colitis, esophagitis, or other end organ disease caused by CMV. We will see with the next opportunistic infection, but it's important to underline that iris is a concern with any neurologic disease, not only CMV encephalitis, that is a ventriculitis or radiculitis, but also with other opportunistic infection that involve the CNS. So it's important to defer antiretrovirals in these patients. This is the treatment for CMV retinitis. You know that there is an initial treatment followed by a chronic maintenance therapy. We should differentiate between the peripheral involvement where the risk of losing the vision is very low. So we could decide to treat either with an IV treatment with ganciclovir or with an oral treatment with valganciclovir. And if it's at risk the vision, you should also perform an intravitreal injection of ganciclovir or foscarnet. Or you can, if it's central, the retinitis, it's very important to use only the intravenous treatment. And the most important thing is that if we have an immune reconstitution uveitis, we should use steroids, either local and in some cases also systemic one. When we stop chronic maintenance therapy for CMV retinitis, we usually treat it for 3-6 months. And if the lesions are inactive and the viral load is undetectable and the CD4 count is above 100, we should consider to stop the chronic maintenance. Which chart should we use in this patient, prescribe in this patient? Almost all, I have to say. We have to pay attention to tenofovir diproxil fumarate, but for the rest, it's all green or just a little caution for TAF. We have to pay attention to the drugs that have, when we prescribe antiretrovirals and drugs for opportunistic infection, we have to consider not to overlap side effects. So we know that the risk of ganciclovir is the risk of a bone marrow toxicity. So we have to pay attention. And this patient has also PCP. So probably we should go to foscarnet, and foscarnet has the risk is of renal impairment. So we should not use tenofovir diproxil fumarate, and we should use with caution also TAF. Cryptococcal meningitis is the second opportunistic infection. And also in this case, we will go outside the general consideration about the 2 weeks. This is a migrant from Mali admitted to hospital for anorexia and weight loss. He reported severe headache. Severe headache is really the central symptoms for cryptococcal meningitis. It's completely independent from fever. In many cases, the patient do not have fever. It's important to see that the CT scan of the brain is negative. The CSF that should be performed show for sure an increased pressure of the CSF, but also an increase in protein and 4 lymphocytes per cubic millimeter. I have to say that this number, you should keep this number in mind, because we will see that it will be important in deciding when to start antiretrovirals in patients with cryptomeningitis. As for CMV, usually cryptococcal meningitis is characteristic of a patient with an advanced HIV stage, and also the viral load is very high, and while the BMI is lower than the other patient. When we talk to when to start, we should consider that the trial that have been conducted on patients with cryptococcal meningitis have been conducted in the countries that are endemic for this opportunistic infection, so mostly in Africa and in Asia. In this case, we are in Africa, and we see that the graph, the 2 lines in the graph are inverted. So it's much better the survival in the delayed arm than in the early treatment. Why this? Because the risk when the CNS is involved is of iris. But is there any specific risk for iris? Is something that we have to, take into account when we see some peculiar exam or symptoms or sign. So it has been conducted a trial on cryptococcal meningitis, again, in developing countries. And they look at they confirm the same graph as the previous trial, where the deferred ART had a better survival than early ART. But when they split their population between those who had a lymphocyte count in the CSF greater than 5 per cubic milliliter, you see that there was no difference in between the 2 arms, while the difference was very pronounced and very large when the patient was anergic. He had less than 5 cells per cubic milliliter at randomization in the CSF. So in this patient, for sure, we have to wait for 4 or 6 weeks. While in these patients, we should look if really the risk of developing another opportunistic infection is higher than the risk of having an iris of CMV. So, not surprisingly, all the guidelines, either the European guidelines or the DHHS or the WHO guideline, they say that we have to wait more than 4 weeks. So in the EACS guidelines, the panel said, most of the panel said more than 4 weeks, and there were some some member of the panel that said wait until 6-10 weeks because it's really dangerous. So because the problem is that as it was for KS or for all the opportunistic infection, we could have a risk of paradoxical iris, so a worsening of symptoms that were present before ART was started, or a masking iris, that is a new onset of symptoms. I mean, the opportunistic infection was present, but it was not diagnosed. And this is very important to see. The treatment of iris is usually corticosteroids. For TB, we have these dosages of prednisone, 1.5 milligram per kilogram per day, for 2 weeks and followed by half the doses per kilogram per day for other 2 weeks. In TB, we could also, in order to decrease the risk of IRIS, we could also have a prophylactic regimen. It was recently published, a trial on the New England, where you could use 40 milligram of prednisone for the first 2 weeks, followed by 20 milligram in the other 2 weeks. So you see that for TB meningitis, prednisone, oral prednisone for 2 weeks, then taper, PML, methylprednisolone, or dexamethasone IV for 3-5 days, then oral taper. Okay, so when we manage it, which is the treatment, we have the induction treatment that is 2 weeks of duration, and the preferred regimen is liposomal amphotericin B plus or deoxycholate, but we usually use liposoma plus flucytosine. And then for more than 8 weeks in duration is the maintenance therapy, and the preferred regimen is fluconazole. You should consider if the CSF culture is negative, and you should continue the consolidation therapy for 8 weeks from the first negative CSF culture. As I said, the maintenance therapy is fluconazole, 200 milligram once a day orally for more than 1 year. But we could stop it. Actually, I published this paper so many years ago. We should stop it more than 1 year from start ART. Patient who stays asymptomatic for cryptococcal infection and when the CD4 count is above 100 cells. What regimen we can consider? We have to pay attention to fluconazole because azo has a lot of DDIs, and also to flucytosine and amphotericin B, especially for the side effects on kidneys. So I leave to Bill the take-home messages.
Great, thank you so much. All right, so hopefully through our discussion of these 4 OIs, really the take-home points are that really initiating ART as soon as possible with most opportunistic infection, that's usually within 2 weeks. But again, the exception is those infections where you have CNS involvement, and the risk of IRIS are maybe the exception. So there, you want to consider delaying about 4 to 6 weeks after initiation of fungal treatment for Cryptococcus. Always consider drug-drug interactions when you're starting antiretrovirals for the OI, for maybe some of the things like PCP and crypto, they're short-term, but then there's also longer terms in maintenance. So you really want to make sure you have a role in making sure they don't cause any harm. And then finally, for critically ill patients requiring intubation, just remember there are other things available, and always consult any reference you have. But again, I think we listed a really nice one there that's updated annually that tells you, what are the things you can crush? Are there alternate formulations that you can push down a tube? And I will say in there, always remember giving drugs, you want to make sure of what's it. So, not everything goes with tube feedings. Remember, there's some drugs that you need food with, some are an empty stomach. Remember PPIs, remember H2 blockers. So while the crushing and getting it in is important, also remember all the other factors. So it does become complicated. And I think, really having a team approach involving pharmacists in this discussion is really critical to make sure, because you don't want to give someone something that you're going to get inadequate levels. So I think with that, we are going to move to question and answer session.
Yeah.
Again, thank you.
So we have a question from Alan that says, I have a question for CMV. If HIV patient has CMV viremia without end organ damage with low CD4, do we need to put him on prophylaxis? Thank you. It depends on CMV viremia and on the symptoms, because if the patient has fever, even if it does not have an end organ disease, I treat them, not with prophylaxis. I really treat them. I don't know, Bill, what you think?
Yeah, no, I think you said it right. I mean, you're looking for something else. I find, and I just got called yesterday about this. It was a patient who came in. He had many other things. He had lymphoma, new diagnosis of HIV, syphilis, and they sent off a bunch of tests. And then about 2 weeks later, he's coming in for chemo, and they call and they're like, oh, he has low-level CMV viremia, 100 copies. And it's like, do we need to treat? And it's like, I think you found your reason. Clinically, he's on ART. He's better, no more fevers, no end organ damage. So I think in that case, no. But I think Cristina hit it right. You're looking for symptoms. You want to figure out what they have. And again, if you just have fever, then you're concerned and you want to treat that. So no, I agree. Not just for it to be a reason, just like you said.
Yeah, if it's a low level and the patient is completely asymptomatic, you can, wait and see. You start antiretrovirals and see what's happened. Maybe with the increase in CD4 count, it will control the CMV viremia. Something that it's important to underline is that when we say treat immediately, I think that late presenters are not the patient that should receive treatment immediately. Because I think that at first, when you treat someone with a drug for an opportunistic infection, you have to understand how the patient tolerates this drug in order to understand if he develops a side effects, if he is for the drug for opportunistic infection or if it is for antiretrovirals, for example. I really like the presentation of Bill on the piece that could be crushed, because these patients are all very, very complicated. And the idea, for example, in my case, to treat at the same time with cotrimoxazole and with ganciclovir is something that will end up with a bone marrow suppression for sure. So you should change either to a second line in PCP or to foscarnet in CMV. I really like that young doctors attend these webinars. And I know that you could see also, we didn't talk about iris and TB because there has been already a webinar in CCO, so you can look for it. Because it's not easy to, when we talk about antiretrovirus is not easy at all, especially in those who are resistant. But treating OIs is even more complicated.
And I want to piggyback on what you said. I think it's really important. So why did someone get into this? Why are they presenting with an OI? So either they were not engaged in care or they came in care and something drove them away. And then, like Cristina said, you're going to give them multiple pills. They're going to be very sick and then they're going to leave care again. And so I think you have to be very careful and work with patients here because it's really important. You don't want to do harm. And again, I think it's just really, really important. Work with the patient, develop a rapport, talk through this. Because the other thing I found is when someone presents with a CD4 count of 400, 500, and I start them on ART, they come back and they say, maybe a little nausea. I really felt great. But when I have that patient who has a CD4 count of 50, they're very sick when I start them on ART. It's really, unbelievable. They don't really know what to do. They're like, I really feel sick. And then I always say they get into the cycle where it spirals down because then they develop OIs and you're adding more pills to someone who's already sick. So it gets complicated. I think there's another question.
That was asked yesterday. And so we can discuss it now. If newly diagnosed HIV patient presented with iris and cryptococcal meningitis, when should steroid avoided? That is a very, very good question because steroids are usually contraindicated in cryptococcal meningitis. But in iris, I think that the first thing that you should do is to discontinue antiretroviral therapy because it's something that you should not maintain this. And then try with low dose of steroids. But it's, while in KS, you have the weapon of the chemotherapy. In cryptomeningitis, while the patient is on antifungal treatment and you discontinue antiretroviral, the only possibility that you have is to try to use steroids. I would not go for a high dosage, but I would try and see what's happened. But it would be a disaster. That's why it's important to wait, because iris in the CNS, it's a huge problem. It's the same for PML. We didn't talk about PML, but iris in PML is devastating, and the patient could die. I had a patient who died on fostemsavir because he had a PML that was severe. And after he could immune reconstitute his CD4 count after 5 years that he had 5 CD4, he died of PML. So it was, you have to pay attention on iris. And that's why we are doing these webinars. And I think that it's very important not to talk only about, the single pill or 3 versus 2, but to talk about a really opportunistic infection.
And the complexities, right? I've been doing this over 20 years. And like I say, every time one comes in, I make sure I'm up to date. The other thing, and Cristina, you said it, a lot of times I find I'm not challenging, but for example, someone came and saw a patient that I saw and said, oh, the person has CMV retinitis. I said, so tell me what you saw. Well, I want to know what you saw. And they said, oh, cotton wool spots. And I said, well, that's not CMV retinitis. And it was a young ophthalmologist who had not trained. And I remember the fellow looking at me and she's like, why are you challenging him? I said, because cotton wool spots is not CMV. CMV is very classic. There's hemorrhage, there's exudate. It's very different. And I said, and he said, well,
often it's HIV.
Right?
Yeah.
Right. It's just HIV. And so long story short, we debated back and forth and I demanded the attending come and look. And the attending saw and said, no, this is not CMV. And it's like, okay, that's true. You don't want to add ganciclovir, like you just said, that you're committing this person to another medication that's toxic, bone marrow suppressant. So you have to know, that's why you need someone with a little bit of a gray background to sort of, you don't normally deal with these every day anymore. And they're challenging. They look to you as the expert. And when you've only seen one case, so that's why hearing these webinars and always keeping fresh on this is really, really critical.
Thank you to Drs. Mussini and Short, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you and have a great day.